It's a pleasure to be here. I've known Cindy for a while now, and she wasn't sure if she had the right phone number, but yes, I have not changed my phone number. It's still the Seattle number, and so here we are. Um, so I'm a little over a 21-year breast cancer survivor. I've tried to start survivorship programs at several facilities. We'll get into kind of some of the problems we encounter in a little bit later. So I'll just get started. And if there's questions, I think we're holding those to the end. If there's something really, pertinent, a comment or whatever, I'm fine if we interrupt my slide deck, not a big deal. I'm a MD. I went to the University of Arizona in Tucson. I got my MPH at the University of Colorado. My BSN is from the University of New Mexico. I kind of spread my degrees around the four corners because it seems fun that way. I founded and I own the Marquionda Imaginative Medicine Institute. We usually just call it Mimi's because it's way too long. My last name is long enough on its own. So after this little talk, you should be able to define integrative medicine and integrative oncology, name several integrative therapies and the evidence associated with them, find resources and guidelines related to integrative medicine and integrative oncology from nationally recognized sources, and beware of some of the billing options for integrative oncology, because that can sometimes be where people trip up. So what is integrative medicine? So I have hand gestures. I know I'm Italian, don't be scared. So there's alternative medicine, which in my world is this or this. There's complementary medicine, which is this supporting this. It's similar to the sign for help, I think, in sign language. And then there's integrative medicine, which it's all combined. Not necessarily my definition. A lot of people have defined integrative medicine and integrative oncology. Some of the main principles are a very, I don't want to say healthy, and not just shared decision-making, but a true partnership between the patient and the practitioner. We look at underlying causes because we can treat symptoms all day long, but if we don't work on the cause, it doesn't really matter because it just keeps happening. We combine, this is not my graphic. I would have used different words on this circle, but we combine kind of standard medical care with anything else that has bearing on what's going on, that is evidence informed, which is a term that's used a lot when there aren't randomized controlled trials. So evidence-based or evidence-informed. We consider all the factors of wellness. Like Dr. Lindell said, there's not just physical health, there's mental health, there's psychosocial health, there's financial health, there is spiritual health. There's multiple things that go into anyone's definition of wellness. Again, we critically evaluate the outcomes, because if what we're doing doesn't work, then it doesn't matter, does it? And good medicine is based on good science. And we tend to really go towards the more natural, less invasive interventions as much as possible. So there's a comprehensive definition of integrative oncology. And this came about from the Society of Integrative Oncology. And his PhD, Lorenzo Cohen, was one of the founders and past president of the SIO. So integrative oncology is a patient-centered, evidence-informed approach to healthcare that utilizes mind-body therapies, natural products, behavior modifications from different traditions alongside conventional medicine. I would say along with conventional medical treatments. It aims to optimize health, quality of life, outcomes across the cancer continuum, and empower people to prevent cancer and become active participants before, during, and after cancer treatment. Published in the Journal of the NCI, and I think Lorenzo is the fourth author on that. He is currently at MD Anderson and runs our integrative oncology program. He's has a wealth of experience and very, very, very well published. So what are integrative medicine approaches? So a definition is great, but what does that really mean in practice? Natural products, we usually think of dietary supplements. I would say we could expand that category. We're not going to go into dietary supplements today. That's like a whole series of lectures. Mind and body practices. So breathing exercise, we breathe all day long. Many of us don't breathe really well all day long, but we breathe all day long. Even teaching just simple belly breathing, so breathing all the way down with your diaphragm, can make actually a lot of changes, but there are also very specific breathing exercises, yoga breathing exercises, the 4-7-8 breath that is very popular from Dr. Weil, the box breathing that Navy SEALs do too. Let's see, so relaxation and meditation. Lots of things can be meditation. Lots of things can be relaxation. Yoga, Tai Chi, and Qigong. Yoga has a lot of studies done on it. Tai Chi not only is good in this setting, but has also been studied for balance and flexibility in older adults and has an impact on the vitality, if you will, of older adults, because if we can maintain our I think I just said I was old there because I said if we can maintain our balance and our flexibility, less likely to break a hip. Let's see, massage, acupuncture. A lot of people are very familiar with acupuncture, but not everyone is. And there's other things that can be sprinkled in, like we didn't really mention diet in here. Nutrition is huge. So that's great. So we have all these lovely things we can do, but is there any evidence? Yeah, and there's guidelines, which is exciting because back in the day, well, 20 years ago, we didn't have guidelines. I was diagnosed the first day of my second semester of med school, so fabulous timing. I recommend that to everyone. And it was a little bit of a different world back then. And one of my mentors in the survivorship arena is now over a 50-year cancer survivor from her first cancer, she said, for others now. She's extraordinary, but it was kind of a different time back then. Survivorship wasn't really given a lot of attention. But there are papers and there are guidelines around integrative oncology. So studies have been done, not necessarily randomized controlled trials, because those can be difficult to do with some of these interventions. One I thought was very interesting, so I wanted to show to you guys, was the integrative oncology approaches to supporting immune check inhibitor treatments of solid tumors. Like published this year, January 9th. How awesome is that? That's pretty amazing. So there are a lot of papers out there, and now we have guidelines from two, you could argue three, national entities. This is another one, integrative therapies during and after breast cancer treatment, the ASCO endorsement of the Society for Integrative Oncology Clinical Practice Guideline. You see Lorenzo Cohen's name at the end and a host of other people who helped make this one happen. There's the SIO ASCO guideline on integrative medicine for pain and depression. There's multiple guidelines. These are also, the NCCN has a ton of guidelines now in the, the Bible of guidelines. The one for anxiety and depression is dear to my heart because the last author is Julia Rowland. Julia Rowland was the director of the Office of Cancer Survivorship at the National Cancer Institute until the day she retired. The Office of Cancer Survivorship pretty much no longer exists. Once Julia retired, it got retired too and absorbed by NCI. And we haven't seen things like the Biennial Cancer Survivorship Research Conference. The ASCO Survivorship Conference has not been active, if you will. And this is not because of COVID. This happened well before COVID, that these kind of fell off. There are, this was published by Mao et al. In 22. They went through some of the different symptom issues and the integrative therapies used for it, the type of recommendation. They were all evidence-based recommendations, the quality of the evidence. So they went through the entire kind of, how we grade evidence in medicine for the different therapies. And a lot of these, sure, some had weak evidence. There's lots of things in medicine we do with weak evidence, I might add, but sure, some of these had weak evidence, or they had moderate evidence in one category and weak in another, like acupuncture is a great example of that. Moderate evidence of intermediate quality for aromatase inhibitor pain, for general cancer pain, but for chemotherapy-induced peripheral neuropathy, weak. And procedural pain, not even mentioned. So it varied on the kind of pain, which I thought was interesting. But I also like that this graph kind of brings some things together. Anxiety and depression, yeah, scanxiety. I'm sure you all have seen patients with scanxiety. I can say, 20 years later, I don't get scans like I used to within the first 5 years. But when I do get a scan, yeah, there's some anxiety with that because I haven't had them frequently. So I can remember I was having a scar revision and they wanted to do an MRI before my scar revision, which is fine. That makes perfect sense. But wow, I didn't sleep for 2 days before that one because I hadn't had an MRI, a breast MRI in a long time. So it's a real deal during treatment and after treatment. So we found that yoga is helpful in both settings. Relaxation, music therapy, and or aromatherapy, like smelling aromatherapeutic oils, not ingesting them. Very helpful. Reflexology helpful for both. And some things that are a little more active in the post-treatment setting, like Tai Chi and Qigong. Acupuncture, I will say there is a non-evidence-based, actually, opinion on acupuncture, that acupuncture during treatment is not a good idea because of neutropenia, risk of infection. I haven't, and I'll be honest, I haven't looked at this in probably 3 years, maybe pre-COVID. But at that time when I looked, there had never been a documented case of any problem with acupuncture in a neutropenic patient. So I think acupuncture someday could be moved more into the treatment stage. I know I've done acupuncture treatments on patients in active treatment, patients before they start active treatment, after. It was funny where Sydney and I had worked together. I once had a nurse run into my office for stat acupuncture for a patient. That was hysterical to me. Let's see. Oh, and so the first one was anxiety. This one is depression, very similar. I will say, back on the anxiety slide, I went through 8 months of chemotherapy. I had a lot of anxiety over it. I was extraordinarily sick during chemotherapy. Breast cancer patients typically gain weight. I lost like 30, 40 pounds due to a lot of my side effects. I did 3 of the 5 things on here. Definitely relaxation, aromatherapy, and music therapy. I had very specific things I did for each treatment. I also used vitamin A with that, vitamin Ativan, because otherwise I don't think I would have gotten through my treatment. So again, an integrative approach. My oncologist, I always had an kind of an integrative natural medicine bent. My oncologist was very open to that. His caveat was as long as I had experts on my side to advise. And I'm like, well, that's not a problem. I'm in med school at the University of Arizona, which is connected to what was then called the Arizona Center for Integrative Medicine. It's now the Andrew Weil Center for Integrative Medicine. So I had Andy Weil, I had Tarone Lodog, I had Victoria Mazes, I had Anne-Marie Chiasson, and a host of other people gifted in integrative medicine to be my guides and help me through it. So we had a very good team. Unfortunately, not everyone, has those experts that readily available. So yay, because I was diagnosed, in med school when I saw them almost every day. This is a brief snippet from the NCCN, and it also shows acupuncture, massage, and all the other interventions that can be used for various things. Yoga has had a lot of studies on it. So yoga is listed for everything except anorexia. I think we'll see more of this with other things, but the data is still, always coming along. This is the NCCN guideline for adult cancer pain. It's small. I'm not going to read it. You don't have to read it, but just know that there are multiple guidelines, including integrative interventions in the NCCN guidelines. This is just one study that was reporting on the long-term effects on patient-reported symptoms and quality of life when you do integrative oncology outpatient consultations. So when you have that support for your patients. Patients presenting for integrative oncology follow-up had overall mild to moderate symptoms and stable symptom burden over time. The greatest improvements were observed in the patients with moderate to severe symptoms at their initial consultation. So the patients with the most problems showed the most benefit. We see that in other studies, right? But this is a population that sometimes can be very difficult to help in the oncology world. So having any study that supports integrative oncology to help these patients, I think it's kind of a big deal. I just want to throw this in because the Andy Weil Center for Integrative Medicine does have a program that is free. It's a toolkit for cancer care, and it's called Can Heal, and it helps people go through integrative oncology options and things of that nature. It's pretty robust, and it can be any patient can use it. You don't have to be associated with the University of Arizona at all. It's free. It can kind of help people find some other support, and it can help providers learn a little bit more about some things too. You just have to register for it, but there is no cost. And it's a nice support tool. So I don't like to reinvent the wheel. If there's a wheel and I can use it, I want to use that wheel. But you can always recreate your own, or you can collaborate with U of A or not, but it's an option. So great. So integrative oncology is awesome. Patients do better. Everything is beautiful. The world is full of roses, except you have to pay for it. Somebody has to pay for it. So ASCO has looked at some of this for reimbursement and coverage of survivorship services. Of course, the caveat is make sure you verify appropriate CPT codes with your Medicare administrative person and all that. And as we know, a lot of things aren't easily covered, but there are solutions. A standard office visit is covered, right? So if you do the standard things in a standard office visit and document appropriately, you can get things covered. A fabulous way to do stuff is group visits. Group visits have some caveats as well. There's things that have to be included. And the big thing on group visits is you usually need a minimum number of people for it to make sense for the facility. In the past, I've seen this be 6 to 8. I can't remember an incidence where it had to be 10, but we've done group visits in medicine for a really long time prenatal group visits, diabetic group visit, survivorship group visit. You can do it, you can make it happen. You can do group interventions, of course, because usually you do yoga in a group. You can do group acupuncture. We used to do it all the time. Meditation doesn't have to be a solo practice. It can be done in a group. So there are ways to combine things and make a payment structure that could actually work and support the program. Grant funding is an option, kind of like philanthropy is an option. The problem with grant funding and sometimes philanthropy is it's not a guarantee and grants end. So if you have not created a sustainable intervention, when the grant ends, the intervention ends. It doesn't matter how good it was. It could be the best intervention on the planet. If you cannot pay for it, it's going away. So I've worked at programs where they relied on a mix of billing, group visits, grant funding, and well, I don't work there now. So having people actually figure out the ins and outs of billing and how this all works is it's difficult for someone like me. It's probably not difficult if you have the right people on your team, if you have an appropriate coder, billing specialist, if you reach out to people who have made and created successful programs. I'm sure Lorenzo Cohen, he's a lovely man. I'm sure if you reached out to MD Anderson and Lorenzo, he would be very helpful in helping you navigate this kind of billing and reimbursement, because this is what kills programs. And I mean, we know Americans spend well over $30 billion yearly out of pocket on integrative therapies, on supplements, on massages. So people want these interventions or these support tools, and to the point that they will pay for them themselves if they can. Not everyone can. So that's kind of all I put out in slides, because I think it's more important to, have some questions, have some discussion, and like, I am not familiar with what you're already doing at your program, because I know you're doing some fabulous things. And I don't want to be Debbie Downer about the money, but I think we know that in medicine today, if you don't figure out the money, it's going to kick you in the tuchus. So, thoughts?
Well, thank you very much for that talk. I really appreciate it. So when you have these trials, so one of the things that we've done here is we've looked at depression and head and neck cancer patients. So I'm a head and neck cancer doctor, surgeon, and we looked at depression prevention by giving prophylactic antidepressants, and we did a randomized control study, and we actually saw that you can actually reduce the rate of depression with giving a prophylactic dose of escitalopram. But now the next stage that we want to do is, can we do that? Because the argument is, well, what about, can we prevent depression by other means, with exercise, with behavioral health therapies? And the issues that we come up with is, how do you standardize that? How do you follow that, right? It was easy to give a pill, and either you got a sugar pill or you got the pill, the actual drug. How,
Right.
in a lot of those trials and studies, how do they standardize that? How do they follow that? How do they, prove their hypothesis?
Right. So it's social and behavioral health research, which is always fraught with peril. You can pretty much never prove true causality, right? So I suppose what I would do is look at who's put out the recent papers and query them. So, I mean, back in, wow, when was that? 2009, when I was in residency at the University of Colorado at Anschutz, and I was working with some of the survivorship gurus, I will call them, who had done the most studies. I had my mentors there so we could kind of look at some of this, but we could never prove causality. So, I mean, so it's a problem, but you can show improvement, like the one study on integrative oncology that showed improvement, but it's not going to be the same as a drug randomized controlled trial. It never will be. I will say one thing though, like awesome depression, improving depression and head and neck cancers. That's like kudos, because that's a rough course. And I will say that when we did group interventions and had multiple survivors together, like magic happens. They will talk about things they will never talk about with us. And the support they build within those group visits, I'm not quite sure how you'd ever accurately measure that, but it's obvious and palpable. So I like group things because it just builds in this extra support that almost nobody thinks is going to happen. Like even the patients themselves are like, oh, I don't want to talk about this or that or whatever. And they become the most interactive person in the group. So the research side, I mean, social behavioral research has been fraught with peril since day one because of it's squishy, right? You can't pin it down. But you can show trends and you can show improvement in outcomes. But yeah, that's where it's evidence informed versus evidence based too.
Yeah, I think that's a good perspective to have. Because and from your point of view too, sorry to hog the questions if anybody else has any, but from the caregiver, because the more I look into this, the more I realize we don't take care of the caregivers for cancer patients a lot of times, and especially in head and neck cancer, that comes at a huge burden to that family from wound care and communication and nutrition and feeding. And but yet, what is your experience with that?
Yeah, so yeah, it's so the broad definition of cancer, of a cancer survivor, right, from NCCS, the National Coalition of Cancer Survivorship, and the Office of Cancer Survivorship when it existed, was not just the patient. It was family, loved ones, whoever your support circle was, were also the survivors. And I completely agree with that. And our system is focused on the patient. But when they are not in the office, the people doing the most work are their family, their loved ones, their friends, their neighbors. It and they are often kind of put aside. It's an interesting problem because sure, we're trying to take great care of the patient, and the reimbursement is around the patient. It's not around anyone else. I've seen, again, like, I hate to call them support groups because they kind of get a bad rap. And frankly, I started a support group with two pharmacy students who also had cancer. The three of us had cancer at the same time. So yay, we had three of us that we could go through it with together. We had all three different cancers. But we started a support group, and I quit that support group because it just wasn't supportive. So the term support group is fraught with difficulty. But for the support people, I mean, checking in with them when they're there with the patient on a visit is huge. Just taking a moment and going, hey, how are you doing with all this? Is there anything we can help you with? Do you need, support for something? Do you need some more information? It could be a very minor interaction, or you can do bigger things. You can have groups for family members, friends, and other caregivers. You can have things that they can do together. it's nothing is as powerful to me that I've seen as them talking with each other. If we can facilitate that and facilitate the building a true community around the oncology center, that's when I think you're going to get the biggest bang.
Yeah, and I think it's a thought process that we have to change in medicine too, you know, because a lot of patients are going to make decisions on how it's going to impact their loved ones, you know, and the person who's taking care of them. Like, well, I don't want to do that because that's going to, you know, they have to take off of work to bring me here, and it's just not worth it.
I don't want to be a burden.
Yeah. Dr. Panwar, you got a question.
Thank you very much for this talk. I apologize for the noise in the background. I'm driving to an offsite right now. When we talk about integrative medicine, oftentimes there's interplay of resource availability and personal or community values. You highlighted how you had significant support as a medical student, and I bet you were cocooned with some of your supportive mentors, colleagues, and other people who had those resources to guide you through this. That experience is very different than, let's say, somebody who lives in a rural town of Nebraska, and their value systems and the resource availability may be different. You may see extremes of what integrative or disintegrative approaches would be. There are people who don't want to engage with anything, including behavioral healthcare or counseling even, or when we talk about prophylactic antidepressant medication, there's probably about half of my patients who say, I'm not sure that I'm ready for that. And then there is the other extreme, which is there are people, you know, now anybody can go on to an AI generative platform and ask, what should I do? And depending on what it was based on, you have patients who ask me about using dog anti-worm medication in integration, not replacement of their chemo or radiation. They'll be like, I can take this pill because I've seen my research says I could integrate this with my care. So how do you as a clinician kind of in that patchwork of circumstances advise us to tackle those kinds of issues in a more meaningful manner? What is a way for you to find resources for patients who may otherwise not have resources? How do you counsel them about the value of this and counteract some narratives that you may otherwise see? Thank you.
Okay, so resources. So when I worked in a rural and frontier categorized part of Colorado, sure, we had things that happened at the hospital, but and now I have patients who are hours away from my clinic, and in the San Luis Valley, we had people who were a significant distance away. Some people, and there's been good research on online support groups, but not everyone is that computer literate or comfortable doing it in a virtual way. We have this problem right now. I have patients who are asking for very specific things, and they're 3 to 5 hours away, and it's very difficult to come up with a solution because it's a solution for one, which then becomes extraordinarily expensive. And then, so it's kind of a trial by error. Trial and error. I mean, unfortunately, there is no one size fits all, and it certainly doesn't fit a frontier population or a rural population many times. There are some things in the community you can collaborate with, because really it all comes down to collaboration. So if there is a church, or they did this in barbershops and beauty parlors that kind of became their own support network. So you have to collaborate with other things in those communities. Now, if it's a community where everyone lives on a couple 100 acres and everyone's a couple miles away from each other, that's incredibly difficult. When I did some more our Native American population, you know, you can give people a gas card to come to chemo or to come to a follow-up visit. Yeah, that didn't work. We had to give people a gift card to the feed store to get hay to feed their horse, or I don't own horses, so that may not be the right food product, but so they could feed their horse, so they could ride their horse hours to come in to like IHS where we were seeing them. So you have to be super creative on how to get things to work, because I can tell you, as a med student, I never thought I'd be buying, you know, oats and hay for a horse to see a patient, but that's what had to happen. The rural and frontier populations, the parts of some of reservations, the access is, it's just very, very difficult. And so you have to you have to think so far outside the box that it seems kind of nuts sometimes. On the AI thing, I am not a fan of AI in medicine, in our media, and pretty much anywhere. So I'm not on the side of AI in medicine being a great thing. I think it's causing a lot of problems, and I think yeah, the AI sourcing of information on certain things, you have no way to verify it. And the average patient doesn't know how to verify anything they find on the internet anyway. They don't know the more reputable sources, which I think some of our reputable sources are coming into question because of things like AI. AI writes so many of the articles that you find on the internet. And there's no references, there's no sourcing, there's nothing. So when I'm talking with a patient, and also I haven't been in an institution in a while now, but when I'm talking with one of my patients, what I get to is what are their beliefs about something. I have a patient right now who's refusing to do a specific drug for melanoma. She has no evidence of melanoma right now. She's supposedly cleared. They want her on something for a year, and she's like, no, I'm not going to do it. And so I need to get down and figure out what really are her foundational beliefs about that, because that's what's forming her decision. Does she have a fear of the side effects? Is it against her religion? What is it? So, and I know she likes to do things very naturally, and I know she doesn't like pharmaceutical entities. But this is a conversation we'll have this week about what is really going on with her. Sometimes it's fear, sometimes it's lack of knowledge, sometimes it's like, no, I don't do that. Like, you know, no, I don't want blood. There are some things that are an impasse and you can't get past. But most of the time, if you figure out what is going on in their head, what they're truly believing, you can come to some kind of a solution that can work. It doesn't always happen that way. I mean, every patient I meet with doesn't end up staying with me. I'm okay with that. Because I'm not what they're looking for, or I won't do everything they want. But I do the best I can, and I try and figure out what they really need or what they're really looking for and why. The whys are super important. Like, I don't want this because, like you said, it's going to be a burden to my family. Or I don't want this because it's going to give me side effects that I won't be able to make dinner for my husband, or, you know, what, you just got to figure those things out and see if you can work with that or work around, or, yeah, it's hard and it takes a lot of time. And in most institutions, you don't have the kind of time that sometimes these investigative conversations need.
And that's why I appreciate your definition of integrative medicine. you know, that it, you know, and comparing that to complementary medicine and alternative medicine, I think that was a key point on starting that on your talk. So really appreciate that. I don't see anybody else with a hand up. Does anybody else have any other questions?
I do. Can you hear me?
No, Dr.
Yes.
Holcomb.
Yeah, hi, this is Andrew Holcomb. Sorry, I don't know what button to press for hand up, but you touched a lot, of course, on supportive conversation and physical activity and mindfulness and other things. And I know you didn't talk a lot about medications, but many of the things you discuss have a common thread in that they require some amount of effort on the part of the patient, whether that's traveling to a facility for a procedure like acupuncture or just being vulnerable in a conversation with another human being. And so and I have found that many patients want to talk about supplements, and this seems to be something that is a lower barrier for them, right? If I take a supplement that I can find at my local GNC or a health food store, then I don't have to do quite as much work as maybe going to a support group. Maybe that's not all their mindset, but I know it's a big question that people have. But I have a lot of concerns about supplements. I know patients have problems with the pharmaceutical industry, but in reality, a lot of supplements are very poorly regulated. They have many impurities. There's lots of variability in the concentrations of the materials that are their active ingredients, so to speak. And that's not something that we get a lot of training in medical school and residency training. So I've sort of taken a posture of a cautionary agnosticism. You know, there's potential benefits and harms, and I would advise you generally to avoid those things, but it's probably a lazy approach. So I'm curious if you similarly kind of guide people away from those things, or you encourage that, or if there are resources you would point us to make us better informed when we have those conversations. Thank you.
Yeah, so my history is complicated in the healing arts. I started as a massage therapist, then an herbalist, then a firefighter EMT, then a nurse, then I went to med school, then I got my master's in public health. So, and then I went to fellowship for integrative medicine and all of that. So being that I've been an herbalist for, wow, long time, longer than I've been a cancer survivor, that's for sure. About 10 years longer. I've seen the supplement industry go through a lot of things. We'll just say that. So yeah, supplements are easy. You can pick them up at Walgreens, at the grocery store, and most of those are absolutely horrible supplements. Costco, Sam's, to my knowledge, never did this, but Costco used to third-party verify every supplement they sold. They don't anymore. I still do use a fair amount of supplements, personally and with patients, because there still are some that are very valuable, but the details that you have to really pay attention to, it's extraordinarily complicated. I do not, and anyone who's been one of my patients, and we've talked about supplement and Amazon, because that's the laziest form, right? You can just buy it online and have it shipped to your door. Amazon supplements are the worst supplements to buy ever, hands down, no questions. You cannot verify they are truly what they say they are. And there are so many black market copycats on Amazon. Amazon can't control it. You need to buy anything you're going to buy from a reputable source. And in my practice, so good manufacturing process, you have to test 1 in every 10 batches of final product. That's not good enough. I use companies that test every lot of raw material that comes in, and then also tests every batch of final product. So every batch of raw, every lot of final. If you don't do that, I don't use your products. It's that simple. So quality control is a big issue, and the supplement industry has been fraught with peril on quality control. And testing 1 batch out of every 10 of final product is why we still have recalls. So there are some regulations. I don't think they're enough. If you can't list on your label the scientific name, genus, and species of the herb that's in there, I'm not using you. At the University of Arizona, the Andrew Weil, been a recent change. Andrew Weil Center for Integrative Medicine, we talk at length about supplements and quality control and things of that nature. You know, in the old day, I would go pick my own plants and I knew exactly where it came from. We don't generally do that anymore. There are some people who do, but you know, you don't do that in the practice of medicine. You need quality control verification and things of that nature. There are some studies on certain supplements. Some are on supplements you can find. Some are on the research variety of the supplement. There's classic studies on echinacea that proved echinacea didn't work because they didn't actually use a viable dose of echinacea. So that's not helpful. But, you know, it's another one of those worlds where herbal experts and medical experts need to come together. Now, sometimes you get that all in one person, like Dr. Lodog, Tarone Lodog. She's an MD. She's an herbalist. She's worked at the United States Pharmacopoeia for, I don't know, a long time. She's not that old, so I can't say decades, but almost as long, not quite as long as I've known her. So she melds those things perfectly. But supplements can be a big problem. People bring in 2 shopping bags full of garbage supplements to me all the time. And I have to hand go through them all. I don't know how you guys would do that in your practice. It's time consuming. And there's like a catalog of knowledge that we are never taught in med school. We're not taught in residency. We're not taught in a fellowship unless you do like an integrated medicine fellowship. So you have to, and the other thing going on in the supplement industry is the companies are being bought by, I don't know, questionable entities. Nestle divested in confections and immediately bought 5 supplement companies. Supplement companies are being bought by venture capitalists. Why? Because it's a multi-billion-dollar industry. The venture capitalists don't care what your quality is. They just care what the bottom line money is and how much they're making. So there's all, like, some of my favorite companies recently have been bought by people I don't trust. And I've seen changes in their formulas and I can't verify quality anymore. So I lose those companies. There's still a decent amount of very, very good companies who do research on their products, who really look at what they're trying to accomplish and how the formula does, or the individual herb or the parts of the herb that are the best for that. There are companies who are doing that. They're generally not owned by venture capitalists or Nestle. So it's evaluating supplements is, it's difficult. And then there's therapies where you don't want certain interactions, right? If you're doing an oxidative therapy, you don't want them on an antioxidant. That's probably the easiest example. Like there's reasons we have people stop certain things before surgery, because sometimes it's theoretical and sometimes it's obvious that it could increase their bleeding during surgery. So pointing you to a good reference is actually difficult because they'll tell you things to look for and guidelines, but even looking for a USP symbol doesn't hardly mean anything anymore today, because they still rely on GMP, which is 1 out of every 10 batches. They don't necessarily care if you have the actual name of what is in the product. Yeah, the supplement world is problematic. There's no nice way to say it. And the amount of extra education, learning, and practice, I don't know how to put that in a standard cancer center unless you have an expert in your office. Because I rely on my oncologists, my onc surgeons and all that to be the experts at what you guys do. Because I don't do that. I call on my colleagues all the time. Hematology, especially, I call my one colleague all the time.
Well, I
Because
put that on my agenda to put on here to say, you know, as a cancer center, we probably need to do that and at least have a herbalist that we would be able to refer to say, hey, if you're really interested in this, this is the person I would put you in contact with, and establishing a relationship with somebody like that.
yeah,
So-
I mean, there's some excellent naturopathic physicians who specialize in oncology who would be a great resource.
As you mentioned, that there are herbalists or physicians who are cancer aligned or expertise in cancer care. What kind of credentials are we looking for? Is there any credentialing, or is it, you know, because we see people who talk about like, I'm going to treat X, Y, and Z, and I'm going to test your low T and everything. And sometimes it can be a very frustrating experience for patients and for us when sometimes their medication use pattern is, you know, counter to what we need to do or what we think is the right thing for our patients. So what kind of credentials are we looking, as you mentioned that?
So you have a bunch of different initials. Like there's the naturopathic physicians, the NDs, there's the doctors of Oriental medicine. So there's the alphabet of initials. But like I would say, if they're a member of the Society for Integrative Oncology, that's a plus. If they're not, it's not necessarily a negative, but it's a plus. But like if you're going to hire somebody, another physician in your group, I mean, ask them for a CV. Go, so what do you know? How do you know this? Where'd you go to school? It's going to be a varied background. Not every naturopath is an oncology expert, just like not every MD is an oncology expert. It's people who had a very particular focus and sought out that education. Like Survivorship. When we started Survivorship, I very bluntly at a conference asked for the training program, which did not exist. But we have experts in survivorship, but they don't have a piece of paper to prove it. So unfortunately, it's not as cut and dried. Like you're a member of the American Herbalist Guild. Well, great. But there is no one credential that's gonna, what did the guy who interviewed me for med school said? I'm here to separate out the axe murderers. There's no one credential that's gonna do that. So it's another thing where you have to do a collaborative, you know, like building of the community and figure out who your resources are. And it's not an easy answer, and it's not the easiest thing to do. And some people in the integrative world, if they are approached by people from the institutional medicine world, aren't, you know, there's going to be a trust issue.
Mhm.
So it'll take a lot of work, but I haven't looked at practitioners in Nebraska per se, but I'm pretty sure you've got some. And I don't know how you license your NDs in Nebraska. Every state license ND is different. Some can be primary care physicians in certain states and not in others. And that can affect how popular they are in your state too, like how many of them are available. But there is very specific training in oncology available to naturopaths, which is very interesting because on the, you know, MD-DO side of the world, that doesn't even enter the transom of our minds sometimes, but some of the best integrative providers I've worked with have been naturopaths.
Well, thank you very much for this talk. It's been educational for us all. So thank you. We appreciate your time.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.